with the.
I actually have my slides here.
Oh,
Let me just share this real quick and let me know if you can
yes,
see it,
please.
if it's coming up.
Yes.
Okay, sorry about that. All right, so I actually found my slides here. Okay, so PRP for male sexual dysfunction. I've been doing this probably about 12 years, 12, 13 years now, treating men for male sexual dysfunction, hormone therapy, and longevity. And we've kind of seen kind of a really big trend in this and kind of some of the new science that has come about. And this is just kind of the outline how we're going to talk about it, the physiology, what causes an erection, why you get ED, current treatments and therapies, and the approach to the male patient at consultations, and then of course PRP for ED. So, erectile dysfunction, there's different types of sexual issues that Sina mentioned, like premature ejaculation, Peyronie's disease, as we know about, which is curvature and scar tissue. And then there's anorgasmia, where some men just can't finish or have an orgasm. So what is ED? I guess, simply defined, it's a persistent inability to obtain or maintain. Some people just think it's about obtaining, but it's actually about maintaining an erection for a sufficient time for satisfactory sexual activity. In the male study, it showed about 52% of men aged 40 to 70 had some degree of erectile dysfunction. Smokers are obviously not going to be able to perform as well, as we know, obviously why. And about half of men with diabetes actually suffer from ED as well. In Australia, I just found a study here about 34% of men aged 40 to 69 have some erectile dysfunction. Seems a little bit less in the US, but it's actually responsible for about 20% of relationship failures. And only 1 in every 3 men seek advice and about treatment for this, mostly because they're embarrassed, or if they go to their doctor, they just get Viagra. And that's why, 20 million men, or I think it's even more now with all these accessibility to PDE5 inhibitors like Viagra. They've tried it and they become reliant on it. But we see a failure of it in about 40% of cases, and also a lot of side effects. So a lot of men are trying to seek other types of treatments now to kind of take care of the root cause of it versus a band-aid like Viagra or Cialis or all these cool pills that you see advertised that pop up on your Instagram or Facebook feed now. So the cause of erectile dysfunction, we've kind of gone through some of these already, and this probably applies to men and women. Obviously, we have the one thing I'm seeing a lot of is performance anxiety now, and I think one of the contributing causes of sexual dysfunction in men, erectile dysfunction, is porn. A lot of people, the accessibility to porn now, and the accessibility to be able to just watch it anytime, it kind of increases your threshold, right? So I tell men who have erectile dysfunction, take a porn break, don't watch so much porn, because you're going to need that level of stimulation or watch something, or have to have, some really kinky stuff to go on to even stimulate you. So, and then there's depression. And what happens when you, kind of go into the drug section there too, is when you go to your doctor and you talk about erectile dysfunction or you have depression, first thing they do is they throw SSRIs or an antidepressant at you, versus checking your hormones. Maybe it's your hormones are off. Maybe you're going through menopause. Maybe men are kind of experiencing andropause. So, SSRIs are a big thing. All these other meds we kind of talked about earlier, statins. I mean, how many guys are on statins now? It's like everybody's on Lipitor and all that. We know their statins can actually cause erectile dysfunction. And then, obviously they sell you the drugs on top of that to treat the erectile dysfunction. So it becomes this vicious cycle there. We have endocrine issues as well. Nervous system, obviously, if they have spinal cord trauma, MS, Parkinson's, neuropathy, all these can affect it as well. And then ever since COVID, we've kind of seen an uptick of stress with men as well. So vascular is obviously the most common type, as we see here, and that's just atherosclerosis. I always tell guys, if your penis isn't working well, something else is going on in the body, right? So either you have, it could be heart disease, it could be diabetes, but one of the first signs that that you're not healthy or blood flow's been impaired, or you're not really getting the vasculature and blood flow to every good areas where you're out of shape or whatever, is erectile dysfunction. So if something's going on down there, something else is going on in the body. So metabolic disorders like diabetes, hypertension, obesity, and obviously high cholesterol, and all that. And this is kind of the pie chart here of the causes of ED. Some of it here. I think endocrine is actually bigger now. I think it's obviously we know it's still vascular, but I think endocrine's actually playing a bigger part in it now. It's just from what I'm seeing in my practice. So obviously this is the male reproductive system here. We have the bladder. Really what I want you to focus on is this area here. And let me just put a laser pointer here. Just kind of this whole area here where the vasculature is, and then back here as well. But that's really the part we want to focus on when it comes to reproductive. A little diagram of, just seeing some of the vasculature in the penis here, particularly in the corpus cavernosum. You have two. And that kind of plays a role in terms of where we give the injections and how we use the PRP. But you can kind of see the blood is here and here, right? The blood vessels that support erections and kind of the tissue there are these deep arteries here that we want to repair, and also the microvasculature in there as well. So really those two areas. And then just remembering about erection physiology, it takes some stimulation. It's not a sympathetic drive. It's actually, as we know, point and shoot, as we remember from med school or whatever, it's parasympathetic. So when you're relaxed, you're able to achieve it better, and you get the release of nitric oxide, and that's where Viagra works to relax those smooth muscles in the arteries. And that's how you achieve the erection. You get the arterial dilation. The penis fills up with blood, et cetera, and then you get venous compression. So when it fills up and expands, it's also blocking the veins from getting the blood flow back, which helps with the erection as well. So if you have overstimulation of sympathetics and drives, it can actually cause constriction. And what happens with that, if you're too, performance anxiety and you're too nervous or whatever, and you get that sympathetic drive, blood flow is going to go back to the major organs, your brain and your heart, and the parts where it's trying to preserve, as if it was fight or flight. So you get detumescence, and that's when your penis kind of shrinks. And that's where I see a lot of guys suffering from too, is with a lot of performance anxiety. This is just kind of the pathway here, how Viagra works, nitric oxide, PDE5. This is actually the area where Viagra works as well, and a couple of the other medications that we use. Just another kind of a view of here, what happens during the erection, kind of what you can see the blood filling up here into that area here, but it is those deep arteries here in the corpus that we kind of see where we want to, attack and kind of help the blood flow and repair the tissue and nerves there as well. So kind of a cool little view here of how the erection happens and what happens and what it looks like during an erection there. Just the major arteries that go here, you can just see here, I just kind of listed them here. It's kind of an old textbook vascular scene there. So first line therapy, I always tell guys, you got to have some lifestyle modifications. I think it's a blend of all these, right? You got to start exercising, eating right again, adjusting your medications that you're taking. So if you're taking a lot of crappy medications that could be affecting it, really need to look at that as well, as we talked about earlier. Second to the oral agents, I don't necessarily agree with this. I still think, this is just kind of what the textbook says. And, you should start using Viagra next, and then calcium, counseling, and then vacuum pumps on top of that. I don't know if I necessarily agree with that. I really try to get my guys to focus on number one first, and then, use something like regenerative, like PRP. Third line treatment, I actually like this one a lot here, is it's basically the penis shot, if you will. It's a bunch of trimix and a bunch of medications put together to cause vasodilation, to cause smooth muscle relaxation. It's almost a guaranteed erection when you use this. And guys like it because it's given locally. It works almost immediately. You don't have to think about it. Viagra, it takes stimulation. It takes, you get side effects, stuffy nose, upset stomach, headaches, backaches. I hear that from a lot of guys, and they don't like it. So ICP, as we call it, you're injecting right into the penis. You're going to get an erection, but we have to also worry about priapism. So that's the big thing, is we've got to worry about, it lasting too long, or if it's too powerful, they may not come down and you end up in the emergency room. Fourth line treatment, hopefully you never get here, but a lot of guys have this as just a penile prosthesis, that they get implanted by a urologist, and they have to pump it up and do all this stuff beforehand. It's not really sexy when they, before intercourse to kind of do all that, but it does work. But there is a failure rate with them too. If it fails or breaks, it's difficult to replace, or not at all. That's kind of like what it looks like on the inside. So hormone replacement therapy is kind of what I specialize in. And this is really what I love about what it does for men. It increases their libido. You get increased pelvic floor strength. It really helps them they get better blood flow there. They start telling me they have better morning erections, which I think morning erections are almost like exercise for the penis. Like we'd exercise in the morning, well, you should be waking up with an erection as well. There's different types of ways to do it: topicals, creams, gels, injections. I prefer the pellet therapy in my practice. That's what we use. And then secondarily, the injection therapy. Then we have the shockwave therapy. This one I usually combine a lot with PRP, a lot of guys are hearing about the shockwave therapy. So they're doing shockwave therapy more now. And I usually use it in conjunction with PRP, because we're really taking a regenerative approach here, right? We're really focusing on the vasculature, destroying plaque, improving blood flow, improving nerve endings and all that, and really improving neovascularization, if you will. So it requires multiple treatments, but it really is a way to, help guys start, taking care of the problem at the beginning, and then incorporating that with the first line therapies like exercise and lifestyle improvements, weight loss, et cetera. They really see good results with that. Then there's some stem cell therapy that we're starting to see kind of on the rise now as well. I've kind of seen some mixed results with that. I just want to go through a quick thing on the consultation that I do with guys here. It's really, the general practitioners are the first point of contact, and they're usually dismissed or they're given pills to fix their problem. It really requires like really strategic assessment of the patient, counseling, follow up. I mean, empathy towards these guys because a lot of them are defeated. They've lost their relationship. They can't perform as well. They're really not feeling good when they come into you, and they suffer from this. So it's really, but I think the good news is we can tell them that ED is treatable. It is, we can treat it now, and we can take care of the problems at the root cause of it. A lot of questions that I ask them: are you depressed? Is it causing depression from you? Are you worsening it with SSRIs that you've been given by your primary doctor? I review their medication lists and try to reduce or substitute them. Maybe tell them, your cholesterol is so low now. Why are you taking a full statin? Maybe you just need half a statin. You don't need to take a statin. A lot of times the statins are the root cause of it, and they don't feel good after they start that. I always tell them encourage cardiovascular activity, weight loss, diet. Really, what I tell them to do is start exercising more to increase blood flow below the waist. This is key. I tell them you got to start doing more lower body exercise because if you're increasing blood flow below there, it's also getting to the penile area as well. So a lot of my guys start exercising. They do light weights, and it doesn't have to be heavy, but increasing their cardiovascular, doing air squats with light weights, and they notice they have better erectile function with that, especially when you combine it with other modalities like shockwave and PRP. I always encourage to have the spouse join because a lot of times the spouse doesn't understand this. They're like, you're not attracted to me anymore. Is that why you have ED? You must have erectile dysfunction or you can't get it up because you're not attracted to me anymore. So I want the spouse to join so they understand that this is not necessarily due to that. It's actual something that men suffer, just like women suffer through menopause, and they may have dryness and painful intercourse. It's the same thing with men. It can happen to them too. And then I ask the patient, has he lost a lot of size? Because a penis, like any muscle in the body, if you don't use it, you lose it. I always flex my arm and I say, if I don't use this muscle, what happens to that muscle, right? It's going to shrink over time. And if you don't use your penis for years, you're going to notice it gets atrophied and it starts shrinking. So that's one thing I ask my patients as well. And I encourage them to start getting better blood flow there with treatments. Are you getting morning erections? When did you start noticing that you started having the ED? Did you have another health condition? Were you diagnosed with diabetes, heart disease, whatever at that time? And then also the degree of the erection. When you say you can't get an erection, what do you mean by you can't get an erection? Is it you can't penetrate with it? You can't last with it? So is it penetrable? Is it hard enough to penetrate? And most of the time it's not, or they lose it. They get it up for maybe a few seconds and then it goes down. And just to compare it, I'll say, so when you get an erection now, I want you to compare it to when you're like 18 years old. When you're 18, that was an erection. Are you getting that amount anymore? And 90% of the time it's no, I don't achieve that amount of an erection anymore. Ask them how it's affected their current relationship as well. I always check for, when you do the physical exam, any penile abnormalities, lesions, bruisings, curvature, if there's atrophy there. And I don't know if it's, smaller for them or not. So I'll ask the patient, have you noticed a lot of loss of size here, especially at the base? You'll see a lot of these guys at the base of the penis. It's kind of just very atrophied and skinny, and then it gets kind of thicker. So that's really key there. Are they circumcised or uncircumcised? To see if they, just to kind of document that on your physical exam. Prostate, sometimes they do that, but most of the times they've already had a prostate exam exam with their regular doctor. So with PRP, it's kind of the goal of PRP obviously is to improve blood flow, right? It's neovascularization and angiogenesis, which means improving the blood flow there, creating new blood vessels, and getting those blood vessels to heal. There's strategic areas on the penile shaft, as we saw in the pictures earlier, that I target. You want to induce somewhat of an inflammatory response to signal the body to heal that organ, just like PRP does. And you really need to use quality PRP to achieve those positive results. Again, I use them in combination with other therapies just to give guys the best shot at being able to function again. This is kind of the mechanism of action. I think Sina kind of talked about this earlier. We got angiogenesis, we have neurodegeneration. We also have smooth muscle and collagen remodeling. That's why we use it for aesthetics as well. But it helps helps with the smooth muscle and the collagen remodeling there. Also taking away scar tissue as well. We inject it into areas like if they have Peyronie's disease, we like to inject the PRP there to improve the scar area. We use that in combination with some shockwave therapy as well. Then obviously over time it has an anti-inflammatory and healing effect with PRP. So the results and benefits that we've seen with it is obviously what I said earlier. A lot of guys tell me their size and length comes back. I think that's just from better blood flow and improvement over time with like exercises I call for the penis. It helps increased appearance, helps with Peyronie's. They get some increased sensitivity from the neurogeneration there, increased stamina. They get more frequent morning erections. And then they get a better response to ED meds as well. So they'll say, you know, I'll take a Viagra after PRP, and I notice I get a better response now with it. Some contraindications I just go through real quickly here. Obviously, if they have herpes, you see an active herpes infection or sores there, I kind of wait off and tell them to have that go down first before we do the PRP. Obviously, if they have a penile prosthesis, they have really bad coagulation disorders, the platelets, if they have a Folian, obviously, or the current UTI. Sickle cell patients, I tend to not do this in either. And if they have severe anemia, and you may want to consider if they're on some anticoagulation therapy, if you want to do the procedure that day, or maybe they should hold off a day because you may have a lot of bruising and bleeding with the procedure. Ideal candidates for mild to moderate, these are just mild to moderate are your best responders, especially if they poor responders to Viagra. And then men seeking regenerative versus symptomatic approaches, like just throwing pills at it. You know, regenerative medicine and longevity medicine is getting more popular now. So those are really your ideal candidates. Less predictable results we see, obviously, if they have severe ED and they just, you know, you've got your really old guy there and they have advanced vascular disease or fibrosis there. Post-prostatectomy with complete nerve transection, it may be more difficult with them. They may end up having to use the injectable therapy for that. And then significant psychogenic ED, those guys are difficult to treat there. If they have a lot of psychological issues there, that they're just not going to be able to get an erection from the beginning. Comparison between the different methods that we were seeing earlier here, like the private shot, the P shot, as we heard, it was kind of, that was the Runnels thing. They use any PRP system. They're using kind of a test tube, and you're not really getting good quality with that. And then, you know, you just do 3 injections along the penis shaft, and then you do it in the head of the penis. I'm not sure why they like to do the injection in the head of the penis when there's no vasculature there. Maybe just for sensation or whatever. I guess you could stick some there as well. But if I'm getting that good quality PRP, I really want to focus on where the vasculature is, which is in the shaft. I use only the M-site system. I do about 4 to 6 injections, depending on the length and you know, and the anatomy of the patient along the shaft. It results in better activation and damage there to start signaling a healing process. Again, I don't do any injections at the head of it unless they ask for it because of vasculature. I don't use calcium gluconate or chloride to activate it. We found that if you use a small gauge needle, I usually use a 31 gauge needle, the small one, because the sheer force of the PRP going through that, you're activating the platelets already. So I don't use it. Some people do, that's fine, but I tend to not use it, and we get great results just using the pure PRP. I don't add any additives to it at all. I just use the pure PRP. No bicarb, no lidocaine, any of that. It's just the pure PRP that we use for it. And I use a 60 cc kit. I get about 8 to 10 cc's of PRP from that. I usually use about 8 mLs, and I do about 4 shots on each side. A BLT cream applied to the shaft of the penis. Some people I'll do a penile block on. It depends on the patient. I tell them it's usually not that uncomfortable. We usually have them numb up for about 20 minutes with the BLT along the shaft. And then I really have them put on a glove and just massage that BLT cream into their penis so that they're really numb, and just warn them that they're going to be numb the entire day after that. You may want to use a penile pump. You may have to do that if they're really obese to kind of extract the penis and pump it out and get it out before you do the procedure. Sometimes they'll use a little Valium if they're really nervous about it. I mean, they're about to get 8 shots in their penis. So, you know, sometimes they may need that, or I'll use Pronox and nitrous oxide laughing gas to kind of help them too. You know, it takes about 15 minutes total. Make sure they have about adequate anesthesia. Clean each side of the shaft. I just use a chlorhexidine or betadine and then do the procedure. I try to pull out the penis as much as possible to visualize it. Sometimes I'll give them a little dose of the ICP, which is the injectable medication to induce an erection, just to get it out so I can see the better anatomy. I'll just give them a tiny dose of that just to kind of what we call plump up the penis, or kind of give them what we call a chubby. So I can hit easier, especially if they're smaller, just to have a larger target area there. And then I injected the corpus cavernosum with it. I use about 1 ml per injection site, 4 on each side of the shaft. It should flow easily. If it's not, then you probably either pierce too deep, if it's scar tissue, or something else is going on. I don't go that deep because if you go too deep, then you obviously hit the urethral meatus sometimes, and they can have blood there. But these are the injection points that I usually do along the shaft there. Again, I try to get a lot at the base of the penis and then kind of work my way up from there. I always start medial or not medial. I'm sorry. What's the word? I don't do distal first. I kind of do it more proximal. Then I work my way distal. So I start down here and then kind of work my way up this way. Procedure continue. You may want to have them pump after that you have a penis pump that I usually give them afterwards and just kind of circulate the PRP there. And they're supposed to do that continuous for like about a month or month and a half or 10 minutes a day, just kind of helps them anyways. There's going to be some bruising, especially if you're pumping, you're going to get the injection site's going to pull blood to that area. So I always warn them about some bruising after the procedure, maybe some soreness as well, but I really don't hear guys complaining about that. They may pee a little blood if you pierce too deep. So just be careful of that. You can usually resume sexual activity in 1 to 2 days. Most guys don't have any issues with that. And then if they're on injection therapy, you just have to warn them if they're using the injection therapy to induce erections before sex, just let them know they may have to reduce their dose because now that they're healing and the PRP is working, they're going to have a higher chance of priapism when using that type of therapy. Treatment frequency, I usually tell the patient they need about 3 sessions, usually spaced about 2 to 4 weeks apart. Most guys wait a month or so, and then we just do about 3 consecutive ones, and then a maintenance one every 6 to 12 months after that as a booster, just to make sure that keep the tissue healthy, et cetera there. We're starting to see now, I'm starting to combine it sometimes with exosomes now. I haven't done it with stem cells, but I definitely use it with shockwave therapy. We still need some randomized control trials for this to kind of, what is the standard dosing and preparation and long-term efficacy? Well, this is what I do. Probably Dr. Trong and other doctors don't do it, may have some modifications in this. But personalized regenerative medicine is really key. It's potential because you really have to tailor it based on the patient. You can do these types of treatments, but what if their testosterone's low? What if they're on all these medications? You really got to focus in on the patient and find out what's causing their ED, right? Are they out of shape? Is it their hormones? Is it their meds? Is it whatever it may be? But you really need to take that personalized, tailored approach to find out the best ways to treat them for ED. But obviously, we know a lot of it has to do with vasculature. So that's why I think PRP is really one of the great treatment for erectile dysfunction and sexual dysfunctions in general. That's all.